Good afternoon. I'd like to welcome you all to today's webinar. I'm Dr. Tamala David, Associate Professor in the Department of Nursing at SUNY Brockport. Today's webinar is the third of a three-part series hosted by the National Academies of Sciences, Engineering, and Medicine to explore issues related to the COVID-19 pandemic and disaster preparedness for vulnerable populations. This webinar series represents a collaboration of three ongoing convening activities at the academies: the Forum on Aging, Disability, and Independence, the Forum on Medical and Public Health Preparedness for Disasters and Emergencies, and the Roundtable on the Promotion of Health Equity. Today's webinar will consider the needs of individuals living with disabilities and older adults, whether efforts to include these populations in disaster planning and response activities during COVID-19 were sufficient, and what lessons were learned. This webinar is being recorded, and the archived video will be available at the link provided at the end of the webinar. I now have the pleasure of introducing Dr. Maya Sabatello as the moderator of this webinar. Dr. Sabatello is an Associate Professor of Medical Sciences and Co-Director of the Precision Medicine, Ethics, Politics, and Culture Project at Columbia University. I turn now to Dr. Sabatello, who will introduce the speakers.
Thank you so much, Dr. David. Today, we are pleased to be joined by three speakers who will each give a brief presentation before we engage in a joint question and answer session. I will briefly introduce each speaker, but you can read more about each one of them in the bio sketches that are posted online. First, Dr. Teresa Blankmeyer-Burke is a professor of philosophy at Gallaudet University. Dr. Burke is the only signing deaf philosopher in the world with a doctorate in philosophy. Her academic publications are in bioethics, research ethics, policy, and sign language interpreting ethics. Next, we will hear from Dr. Scott Landis, an associate professor of sociology and faculty associate at the Aging Studies Institute at Syracuse University. Dr. Landis' most recent work focuses on evidence for the more severe COVID-19 outcomes among people with intellectual and developmental disabilities. Finally, Dr. Michael Sayers is the program manager for the Office of Public Health Preparedness in Monroe County, New York, and he will share his on-the-ground preparedness planning experiences and lessons learned from the county's COVID-19 response. Thank you very much, and Teresa, you've got the stage.
Hello, everyone. Just doing a sound check since I'm deaf. Is my voice coming through okay? Interpreter? Yes, thank you. So thank you for the opportunity to participate in this webinar, and thank you to the National Academies for hosting it. I am a deaf bioethicist with voice privileges. I'm fluent in American Sign Language and also in spoken English, and I teach courses on bioethics and disasters at Gallaudet University, which is the world's only liberal arts college for deaf, hard of hearing, and hearing students. And we have courses that are taught in ASL and in written English. So because of our student demographics, one of the things that's really important to me is that our students and the members of our community know what needs to be done in a disaster. And I think we've all learned a lot of lessons from this pandemic that we're currently in. Just about everyone I know with a disability has a story about how a disaster emergency event unfolded and they were unable to have the right information at the right time or the right access that they needed. So one of my most vivid experiences was about 20 years ago when I had an infant and a 5-year-old. I'm standing on the front porch of my house in downtown Albuquerque, looking out towards the Rio Grande, which is maybe a half mile away, maybe a little less, and watching the forest around it erupt into flames. I could see the flames from my front porch. I did not have access to any emergency information, even though at that time, this information was by law supposed to be available to me. So We have improved since then, but we can do a lot better. Since April 2020, I have been working with the New Mexico Disability Access and Functional Needs Committee. And so with this limited boots on the ground experience, in addition to my theoretical disaster bioethics experience, I wanted to bring 3 points to you today. So those 3 points are communication, communication, communication. Let me expand on that. So bringing disabled people in at all parts of the process for disability disaster preparedness is something that we absolutely have to do. And that means talking to the community and asking people what is needed. It means including disabled people, not just on DPAC committees, disaster emergency planning advisory committees, but also bringing people in when, for example, you are in a rush to develop a website for your state or community that allows people to register for vaccines. If there's no one with that expertise or knowledge in the room, it often gets overlooked. And I think we're all well aware of many examples from this pandemic where that has happened. The second thing I want to mention is it's really important to think about multiple methods for delivering information and continuing to deliver information in a variety of contexts and settings. So, for example, it's often assumed that if you provide information by text message, that's enough for deaf and hard of hearing people, and it's not. Another thing to consider, here's an example right from the COVID pandemic in New Mexico. So during the height of the COVID outbreaks on the Navajo Nation, one of our responses was to house high-risk individuals who had a COVID outbreak in their home in local hotels. And this was, of course, to reduce their chances of contracting COVID. But even though the ADA has been around for 31 years, there are still hotels and motels in rural parts of the country and in cities that are not fully ADA compliant. So that's an issue that came to the fore. Another one is figuring out how to get information out to people when the access to technology for a variety of reasons is not available. So in states like New Mexico with large rural areas where there's a lack of cell phone coverage, and there's also a lack of other infrastructure like running water, how do you communicate with people? Well, one thing that we did was to provide flyers around communal water tanks sites where people would drive to fill up their containers with water for their homes. Now, these flyers had information in 3 languages, Navajo, Spanish, and English, and also images to update people about public health practices, physical distancing, hand washing, vaccine distribution, and the like. And the final communication point I want to mention is figuring out how to not only develop communication practices that work for a particular disaster, but that work for disasters that are overlaid on top of each other. So in New Mexico, we had wildfire evacuation last summer during COVID. I had numerous text conversations with deaf Texans last winter who were managing the freeze crisis. So this is another thing, the informal networks that people with disabilities develop to keep each other informed is something we may want to think about leveraging. We've learned a lot the hard way. And we can learn and do better. As an ethicist, I like to think that people are really trying to do the right thing. This webinar is evidence of that, but without including disabled people in the room, whether it's a virtual Zoom room, whether it's some other kind of communication, whether it's a physical face-to-face space, without including disabled people, it's really hard to anticipate what the needs will be. Thank you very much.
Thank you very much, Dr. Burke. Our next speaker is Dr. Scott Landis. And Scott, please take it from here.
Thank you. Early in the pandemic, we expressed a concern that people with intellectual and developmental disability may be at increased risk of more severe COVID-19 outcomes. And we did this for a few reasons. From prior studies we had conducted showing patterns of comorbidities in this population that the CDC was early on identifying as risk factors for more severe outcomes, higher risk of pneumonias, pneumonitis, dysphagia, swallowing-related disorders. The second reason was that we know that a disproportionate percentage of this population resides in congregate settings. Estimates are between 16 and 25%, many times in residential group homes. And then third, because we know that there are challenges to social distancing related to the care that people with intellectual and developmental disability often require. That there's some types of care, not just for this population, but also for older adults that you just cannot socially distance. And you add to that some type of cognitive limitation where the person receiving care may not understand proper procedure for when to wear a mask, how to wear a mask. We were really concerned up front that there would be increased spread of cases and possibly deaths among this population. Unfortunately, we were correct. I'm going to quickly highlight some findings from a few of our studies, and I will go through these quickly, but just wanted to give you a little bit of background. If you want more information on what these studies, feel free to reach out to me via email. Next slide, please. So this first slide shows some results of tracking that we did. We tracked 30% of those receiving residential group home services in the state of New York, and they're represented by the white line at the top. And the orange line at the bottom is New York State overall. And what we're looking at here in these slides are case fatality rates. So the percentage of people who died among those diagnosed with COVID-19. And so what we saw consistently in our tracking of the New York State data, and we've actually now taken this through April of this year, and it's a consistent pattern, is that the case fatality rate has stayed between 1.8 and 2.2 times higher for people with intellectual and developmental disability residing in group homes compared to the state overall. Next slide, please. So from here, we moved on to some data we obtained from the state of California. The benefit of the California data is they divide the intellectual and developmental disability population into types of services received. And so we could better nuance the settings in which people lived. What we found here is that people with intellectual and developmental disability living in either their own home or a family home, their case fatality rate was only slightly higher than the general population, 2.8% compared to 1.9% in the general population. It's people who were living in the congregate settings, the group homes, the ICFs that did not provide nursing care, that had case fatality rates that were between 2 and 2.5 times higher. However, one thing that was really important to see is those folks who were living in settings that provided 24-hour nursing care, indicating a higher level of medical need, had much higher case fatality rates, 16%, 20%. And so this helped us begin to discern a pattern that, yes, congregate care does appear to be a risk factor for this population, but it also has something to do with medical need and whether the person is receiving nursing care. Next slide, please. And so then in one other study, we actually obtained data from 12 states across the US. And I've got them in here, but you can email me afterwards if you want to know more about this study. And trying to get an idea of, was this consistent? Was this just New York and California, or were we seeing this across the US? And we did confirm that this was a trend across all 12 of these jurisdictions, 11 states and the District of Columbia. And what we found is, compared to the general population, again, people living in their own home or a family home who had intellectual or developmental disability actually were doing better than the general population, had case fatality rates lower. But those living in some type of residential congregate setting had the 2.5 times higher case fatality rates. Next slide, please. So what these studies, and this is just, like I said, a quick overview, have showed us is that there is indeed a risk of increased, more severe outcomes for folks with intellectual and developmental disability in the US. Much of it is related to type of setting, where the person lives, with congregate settings leading to higher case rates and case fatality rates, which makes sense. There's also some evidence, and we show this in a recent study we have out in JAMA Open, that people with Down syndrome in particular are some at the highest risk. It underscores a few points that I just want to real quickly go over. With this greater risk in mind, I think it's time we look back at some of the decisions that were made during the pandemic to try to discern whether they actually exacerbated the problem. And the first one I think we need to address is that these residential group homes for people with intellectual and developmental disability were not afforded the same public health prioritization that we provided for hospitals and nursing homes in the US. And so early in the pandemic, and this was consistent across US states, these group home workers and providers were scrambling to get PPE and rarely were able to get the amount of PPE that they needed. And you hear awful stories about people having to take their off hours to go door to door in their neighborhood to beg neighbors for PPE so they could go to their job, have them for themselves, and also for those that are providing services. I can't help but think that this really did exacerbate the problem, possibly increase the spread, but it wasn't just PPE, it was also access to emergency funds. And so one thing going forward we have to think through and really be aware of is that these direct service providers that are providing services for folks with intellectual and developmental disability are in effect, and especially during a time of crisis, serving as public health providers. And I think we need to begin recognizing them as such and providing them the prioritization that would actually entail. The second thing that really became apparent during the pandemic is that the wage for these direct service providers is not sufficient to keep them from leaving the job and either going to another employer where there's less risk or just not coming back at all. And we've seen a real crisis in the state of New York as well as across the US where we don't have enough service providers. And I'll go ahead and stop there. Thank you very much.
Thank you very much, Dr. Landis. Our next speaker is Mr. Sayers.
Hi, everyone. Just waiting for my slide to come up. So the title of the slide takes an idea from a 2017 article written by a former FEMA administrator who wrote about planning for the community versus planning for the plan. It seems like an obvious thing to do, but not every community planner does it. We adopted this philosophy in Monroe County in several ways as listed in the bullets below. The first bullet, preparing people with disabilities. Pre-COVID, we went to the Center for Disability Rights headquarters and the Rochester Institute of Technology's National Technical Institute for the Deaf and presented a series of 6 classes on accessible preparedness to these communities. First one was on the 5 W's of preparedness. Then we went into individual preparedness, building individual and family emergency plans. Our 4th class was preparedness kit building workshop, practicing preparedness with emergency drills. And lastly, we went into an accessible preparedness train the trainer course, meeting these community members and leaders pre-COVID and planning with them helped us in our COVID response. We really better understood their needs going into this. In the second bullet, getting to the decision makers, it was already alluded to by a prior speaker about the challenge of PPE and group homes. We were involved early on in developing our county staging site, and in Zoom calls, we would discuss facility PPE needs. Long-term care administrators, not patient-serving clinicians, dictated what they thought their staff needed for PPE. But we discovered that operational staff like nursing managers knew what was really needed and also requested changes separately to what was agreed upon at the higher level calls. Adding to the confusion, these nursing managers were changing several times during the pandemic. It was difficult to sustain our points of contact, but our lessons learned was a real need to get to a decision maker who knew what was happening on the ground. Too often, the facility senior leaders were disconnected from the day-to-day operational need. Under the third bullet, understanding community capabilities. For us, this was very innovative. In the beginning of the pandemic, assisted and independent living facilities did not have medical directors, so we could not coordinate and have a whole facility tested if several residents or staff got COVID-19. all had individual doctors from across the region. Through a collaboration with several area geriatric physicians that had patients in many of these facilities, our health commissioner, Dr. Michael Mendoza, appointed them qualified representatives pursuant to New York public health law and the New York Code rules and regulations. It gave them the authority to order and conduct testing of the residents and staff of named designated facilities. This helped us to quickly determine how big a COVID outbreak was occurring so we could immediately implement proper isolation and quarantine operations. It made a major difference in our response. Under the fourth bullet, understanding community characteristics. This proved invaluable since the deaf community is so large in our county also. I know we've already talked a little bit about the deaf community earlier, but we already realized the need from our earlier interaction just with NTID. But we had established a bi-monthly college-university call that discussed COVID-19 questions with the 7 local college universities, including NTID, that this was going to be a need. We had already established memorandums of understanding with all these institutions also on how we were going to handle their student cases and contacts. Our deaf case investigator, contact tracer, became a trusted member of our staff in that community. And she was able to get more identified contacts from her discussions than we may have been able to do. Lastly, the bullet on vaccine access for all county residents. This is an ongoing process and includes our migrant farming communities besides what's listed there. Through our county chief of staff, we meet twice a week to identify where low vaccination rates remain in the county and how we will reach out to that community through mobile points of dispensing sites. Generally greater than 25 residents needing vaccinations. Many 2 to 3 person vaccination teams that can reach the smallest numbers in need, for example, 5 people or less, or engaging our mobile vehicle unit that will attend various neighborhood and or festival events in our community. We realized that our fixed sites were no longer working, and this is pretty much across the country. We have conducted about 8 to 10 vaccine clinics of these sorts per week, every week, for several months now. In addition, as soon as we identified or are told of a person who wants to be vaccinated but cannot leave their home, we connect them to our EMS contractor that is responsible for vaccinating homebound residents. Thank you very much. That concludes my presentation.
Thank you very much, Mr. Sayers. And for all our presenters, please turn back your cameras on. And I want to remind the public as we are, all the audience, as we move into the Q&A period, to send us some questions. If you have any, we'd be happy to direct them to a specific panelist or to all of them. I wanted to kick off with one question that perhaps would apply to all 3 of you, which is, what are some of the lessons learned from the COVID-19 pandemic that we should bring forward in future disaster planning for vulnerable populations? And I know that Mr. Sayers has spoken a little bit about that on the Monroe County level, but I'm actually also wondering about how can we move it upwards from local levels to state level and to federal level. And any one of you can answer the question.
I'll jump in. I mean, one thing that I would want to emphasize, and I think it cuts across many populations, not just like those with intellectual and developmental disability that I focus on, is the lack of good health surveillance data in this country for people with disability. And I know it's the case with those with intellectual and developmental disability, but we just do not do an adequate job, or a job at all sometimes, of monitoring the health of this population. And that has been very apparent during the pandemic, where it has been really difficult to get data to see how folks are doing. And so I think one thing that we really could think about going forward, with the assumption that this won't be the end of public health crises such as this, is how do we begin building a surveillance system, a system where we can actually begin to monitor health outcomes, or that we could use quickly to report health outcomes in populations, vulnerable health populations, so that we know what's going on the ground.
Thank you, Scott.
This is Mike. I'll just jump in real quick. One thing, even though we've already talked about the local level, one of the things that I did not talk about today was we have 30 municipalities within our county, and what we've done is we've created sectors prior to COVID where, we used terms to work with. We had coordinators per sector that was working with these communities to identify where they are per sector. Where are the nursing homes? Where are the different groups? Migrant farmers? Where are the folks that are living in their homes by themselves? So in time of crisis, we would have someone to turn to that could work within their municipality, whether it's town, village, or city, that could quickly communicate with these communities, at least know where they are, because sometimes they're not well known throughout. So we've tried to adapt that in all of our planning processes at the local level.
Thank you, Mr. Sayers. Dr. Burke.
Thank you both for those insightful comments. I was thinking about infrastructure and how we already, well, for a long time, we've had laws that support accessibility for people with disabilities. And it's when we have a crisis such as this pandemic that we realize the enforcement mechanisms for those laws, the support to make sure that these smaller entities that maybe don't have as much in the way of resources to comply with our accessibility laws, such as the ADA. All of these have, we've had a spotlight that's been shining on these, because in order to make sure that we have access and functional needs, we need to have the infrastructure ready. And we've had 31 years since the ADA to get this ready. And it's, I think it's a public embarrassment that we have not had that already set up.
Thank you, Dr. Burke. Another question that, kind of came up in your presentation, Dr. Burke, had to do with what I'm thinking about the intersectionality. You've mentioned the Navajo Nation, as well as deaf and people with disabilities. And I'm wondering, how should we think about preparedness dealing with multiple levels of marginalization? And especially, how should we be ready for that type of crisis, which might come up again? And again, I think even just thinking now about, as we're shifting hopefully into more vaccines, how can we do that and address different levels of marginalizations and different concerns that might be among the Navajo Nation, for example, about getting vaccines, but also people with disabilities who might need that or be at a greater risk?
I think that's such a great question. One of the things that we've been doing at Gallaudet University is we've had a series of vaccine hesitancy webinars aimed at particular communities that are intersectional. So it's not just deaf people, but of course deaf people are BIPOC, deaf people are white, deaf people may have disabilities. And so in order to think about all of these different populations and remembering that often in a underrepresented group, if there is a disability component, that component can be ignored or less prioritized. And it's really important, as we're thinking intersectionally, to ask who's not here, who's not in the discussion, who is not in the room, and why that is. So thank you for raising this issue. I think it's an important one.
Thank you. Another question that I think came up from the presentations is really about the need for data. I think that came up on the one hand, Dr. Lendes made it very clear that we're lacking data, while Mr. Sayers highlighted that they've had collected data which enabled them to act pretty quickly compared to other places perhaps in the country. But I'm wondering if you can speak a little bit more about what data points are particularly important for us to record and make sure that we collect them, and at what level it should be collected. Is it in hospitals? Is it statewide? I mean, how do you think about who should be collecting the data and what data should be collected, as well as especially with, again, those folks who might not be accounted in usual surveillance processes, how should we reach out to them as well?
Well, I'll just jump on it from a local level. I think one of our challenges locally, probably, I'm sure at state and federal level, is that so much of the data collection is stovepiped. And what I find out is when I work with our partners at the local county level is trying to combine those efforts, whether it's with the Office of the Aging, whether it's the Center for Community Disability Rights, how can we collate those better? Within New York State, we created some regional hubs that brought in 9 counties above us at the county level, but it really helped us collect that data that was maintained through primarily the University of Rochester, that was able to break through quite a few of those stovepipes through that effort.
Dr. Lentis?
I think one thing that's important to recognize is there are some instances where this data is being collected, was collected, but was not shared. And to me, that would be a starting point, would be to maybe see if we could increase transparency. I know many states, including where I live in the state of New York, for folks with intellectual and developmental disability, the state was requiring from the beginning of the pandemic for providers to report COVID-19 outcomes. But the state chose not to share this data for over a year. And so, whereas other states like California began sharing data very early on in the pandemic. So I think a good starting point would be to try to get an idea of who is already collecting data and to see if we can work on standardizing systems, but also increasing transparency. I think the other thing, and this is to me one of the upsides of what I've learned during the pandemic, is how many individual providers or consortiums of service providers are already collecting data, have realized that they need to do so in order to ensure the best health of those that they serve. And some of these are doing a really good job of collecting high quality data. And so I think one thing that we maybe could also try to maximize is cooperation with these entities that are already doing so, even beyond government levels, but on a private level, to see again if we could come up with some standards like you hinted at, of exactly what needs to be collected, what are the measures that we should have in place, and how could we share them. I know NIH is trying to do some work around this, but I think it's going to need to be a much more collaborative effort across state organizations, but also federal agencies.
Scott, I'll follow up with you for a second on that. So systems that have collected data relatively successfully and haven't been transparent about it, or started to be transparent later on, do you have a sense as to how many collected information about disability status? And I'm talking about not, just people with intellectual and developmental disabilities are more likely, as you mentioned, or not more likely, but they are actually more likely to be in some residential setting and congregate care, and therefore they are more accounted for. But a lot of people with disabilities live in the community independently and are not registered in any one of those lists. And I'm wondering if you happen to know, and it's kind of off the bat, so if you don't, that's totally fine, but I'm wondering if you happen to know of any state that actually collected disability status information and made it transparent in the context of COVID-19.
It's a great question. Not to my knowledge, and I think you're exactly right. Not everybody is receiving some type of formal services. And so even if you went through a service system, you're going to miss a large group of this population. I think you do have some individual level providers they're usually the ones doing some type of service coordination work, where they're not the actually direct service provider, but they're helping coordinate across agencies. And so they might serve 25, 30, 40,000 people. And we'll typically have 80 to 90% of their service population that don't reside in any congregate setting, live in their homes with families, and maybe only getting a few hours a week. So they're getting a minimal amount of services. And so those agencies have collected data on disability status. But I think, again, it still is leaving out that group that just doesn't receive any services. I mean, I kind of always my hope was always, I know it didn't happen, was maybe the CDC would start requiring reporting of disability status when they started looking for demographics. But I mean, to me, that would be the great answer, but that's not occurred so far.
Thank you very much. We have a couple of questions from the audience, so I'm going to move to them. One is from Jose Parodi, saying, thank you for your presentation and sharing the experience in the Andean and Amazonian peoples of Peru has been isolated and postponed. There are several factors for this related to communication channels, internet access, telephone, and even the little presence of state support services. They speak another language, have a lower educational level, and another culture. The effects of emergencies are devastating in these populations, and the question is how to prepare them in the short and medium term. And I'm not sure if it is aimed to anyone in particular, but I actually think it brings in some questions about, for example, the issue of communicating COVID-19 information for people who might have lower literacy level, as well as perhaps technological divide, as we know that's a big issue. So how can we address some of these issues? And I don't know, Mr. Stayers or Dr. Burke, if any one of you can speak to that.
Well, I'll jump on first. I mean, in our community here in Monroe County, we receive approximately 800 to 1,000 refugees every year from around the world. And so we're pretty attuned to using our language line, our interpreters, to be reaching out to these refugee communities, multiple languages across the board. I think it starts in the very beginning, already establishing those relationships up front. Mondays, we have refugee clinic here in our department, which helps us make connections with not only the various communities around the county, but also with the people that support those communities outside of the health department. They help to connect us with that. So for us, it all starts from the very moment anybody comes inside of our community in Monroe County. We're going to make those connections right away, and we'll build from that. So I think it's kind of hard to come in after the fact. Sort of what we might do right now, like what I said earlier about vaccine, for the migrant farming community, whatever, we're going out to them. So if we have to find out after the fact, you got to go to them. You can't wait for them to come to you at that point. And that's our new strategy for those individuals. So I think it's like either you catch them right in the beginning or you're going to their population with the language interpretation you might need, the keeping everything to a 6th grade level of communication or lower, which is one of our emphases within anything that we put out to the community.
I'm not sure I have much to add to that. That was a great answer. 2 things that came to mind for me is knowing the community. And so if you're going out to the community, knowing where the gathering points are, knowing who the people are who are respected in the community, providing information that is not only text-based, but image-based. And of course, that's not going to work for people who are blind and have low vision. So thinking again about all the different ways that you can use things, very low tech modalities, paper, and just not recognizing that the infrastructure may not be there for the high tech solutions, and going back to where are people who is in the community that can support and sustain this interaction through time as you try to build better infrastructure for future emergencies.
Thank you. I think last one question before we move forward has to do with the use of technologies, and to what extent technologies do you think can be used to help us be prepared for the next round, taking into account that one, technologies may not be available in some locations, and that means that also when we're distributing information, it might not even be in the language or in the cultural narrative of that particular population. And on the other hand, that of course, technologies can offer big data that might be helpful in terms of surveillance. So I'm wondering if you can speak, each one of you, to the effect of the role of technology here in current preparedness, future preparedness, and how should we balance those issues?
I want to jump in first, and I don't want to critique technology too much, because obviously I'm highly dependent on it, someone who looks at data, but I know it's been a real challenge for folks with intellectual and developmental disability who already had struggles with the way that technology has developed over time. And it's in some ways, and especially when you're talking about someone who's maybe not receiving direct supports, this also I think applies to older adults that maybe don't have the supports they need, although they have dementia, cognitive limitations. If we just see technology as the avenue to, disseminate information, that we really are going to necessarily marginalize some of these populations. And so while I agree the importance of technology, I think we can't ever get away from the fact that sometimes it's just going to have to be, going to see someone, getting in a car and driving. And I know, going back to your earlier question, that's what some of my colleagues that were in the Arizona area were having to do for those they support, is they couldn't email, they couldn't do things, over the internet. And so they were just having to drive and knock on people's door, safely distance in the, in the driveway or the yard, but to be able to just share things face to face. And so I think that's the real challenge for some of these vulnerable populations who maybe not going to be up to speed on technologies. How do we use it, but do it in such a way that doesn't lead to further marginalization?
Yeah, and this is Mike. I just add a few comments to that. Yeah, I think we're in the challenge right now where technology is not going to really matter that much. We're in our vaccine push because we're at the point where everybody knows what's going on. What we had to do very early on was really, our recently new administration at the county level brought in community engagement officers, positions that were reaching out to the community. Where does the community get their information? All the various communities. And one example was within our African-American community, not new, but it was through churches. And so we focus a lot of our vaccine push to actually do the vaccinations in the churches and versus making them come elsewhere. So for us, it was more about, through these new staff members, really helping us understand where and how residents receive their information, and then making that work for those residents, no matter what type they are, no matter where they're from, no matter what their potential disability is, or if they don't have a disability. We had to reach out through our community engagement teams, our outreach, to really further identify the exact locations to make this work. It's still a challenge, even when we're out there. Sometimes it doesn't always work, even when we're right there where they get the information. But at the same time, at least we know we're making progress. We're getting them information, and we're slowly chipping away, for example, at the whole vaccine push. Sometimes we go out, when I talked about doing our outreach on vaccine, we might have 5 staff members, but we only get 2 to 5 people. And that's after a 3 or 4 hour effort. But we're actually pretty satisfied with the effort that we're doing, just trying to get those 2 to 3 to 5 people. And kind of that's where we are right now.
So I thought maybe it would be helpful to consider a positive benefit of technology that's come out through this pandemic, and that is the increasing visibility of American Sign Language through interpreters and that communication. Granted, of course, not everyone has access to the internet. Not everyone has a friend with the internet connection. Not everyone can get to a public spot that may now be closed because of the pandemic to access internet. But just this increase in visibility has made a world of difference for the signing deaf community. Now, going back to, again, I feel like I'm beating a dead horse with the comment I keep making about the ADA and ensuring that this is followed, the National Association of the Deaf actually had to sue the White House in order to make sure that there was sign language access during the COVID press briefings. So we have a long ways to go, but I think there are some things about technology that have been a real boon during this pandemic, and I hope that those trends continue. Of course, we have to pay attention to all of the gaps and try to figure out how do we fill these in, how do we compensate for them, and what other strategies do we need to put into place.
Thank you very much, Dr. Burke, Dr. Landis, and Mr. Sayers. These were really great responses, and I'm glad we had the opportunity to discuss them. We're going to move to the last part of this panel, and it's the last part of this webinar series. And we're actually really pleased to have several federal colleagues with us to provide their overall reactions to the webinar series, to today's webinar, and as well as their thoughts about next steps. So I'm delighted to introduce those colleagues to you. The first one is Dr. Daniel Dodgen, who is a Senior Advisor for Strategy, Policy, Plans, and Requirements with the Assistant Secretary for Preparedness and Response at HHS. His expertise includes disaster preparedness and response, climate change, equity and inclusion, health system policy, behavioral health, community resilience, opioids, and other cross-departmental priorities. Next, we have also Commander Jonathan White with us, who is a career officer in the U.S. Public Health Service Commission Corps. He is an emergency manager specializing in the needs of children and vulnerable populations in crisis events. He is currently stationed in the HHS Office of the Assistant Secretary for Preparedness and Response as the Director of Recovery in the Office of Emergency Management and Medical Operations. And lastly, we have Dr. Robin Sue Frobausi, who is the Acting Director and Principal Deputy of the HHS Office for Civil Rights. She has more than 40 years of federal government leadership experience in civil rights enforcement and policy related to health and human services. Please take the floor.
Well, thank you. I'm going to start, but I will try to be quick because we have such great folks. I want to start by thanking everyone for the great discussion today. I know I've learned a lot just in listening to these great speakers, and I hope that there'll be some follow-up with some of you later because this has really been useful. I also want to say that HHS takes the issues that have been raised today very seriously, and we are addressing them in a number of different ways that we'll talk to you about pretty quickly. First, I think most of you know at the highest level, we're working to implement several of the White House executive orders that you've probably heard about. We're also seeking outside input from national experts through our federal advisory committees. We're also working on programmatic activities that Commander White will talk to you about. And fourth, we're working through civil rights enforcement activities that Dr. Frobausi is going to discuss. So let me tell you a little bit about the executive order. I think most of you probably know about the executive order on ensuring an equitable pandemic response and recovery. This was signed by President Biden on January 21st. That tells you what a priority it was. And it begins like this, I'm quoting, "It is impossible to change the course of the pandemic without tackling it in the hardest hit communities. In order to identify and eliminate health and social inequities resulting in disproportionately higher rates of exposure, illness, and death, I am directing a government-wide effort to address health equity." And I think for those of you who follow these issues, you probably know that there are a number of executive orders, EOs as we call them, about equity. This one in particular establishes a COVID-19 health equity task force within the Department of Health and Human Services that is charged with making recommendations to the president for mitigating health inequities caused or exacerbated by COVID-19. So some of the things that we're talking about, there are a lot of people at very high levels in government that are talking about them as well. In addition to implementing these executive orders, we also work to ensure that non-federal experts have the opportunity to participate or at least to make recommendations as government moves forward and tries to implement some of these things that we're talking about. ASPR, the agency I work with, you see it over my shoulder, wait, this shoulder, has 4 such committees. We have the National Biodefense Science Board, the National Advisory Committee on Children and Disasters, the National Advisory Committee on Seniors and Disasters, and the National Advisory Committee on Individuals with Disabilities and Disasters. I'm going to tell you a little bit about the charge of these committees. They bring together nationally recognized non-federal experts to develop advice and recommendations for the HHS Secretary, and they are charged with the following key duties. First off, evaluating preparedness for and response to public health emergencies caused by chemical, biological, radiological, nuclear events, or natural disasters. Two, providing specific advice to HHS's strategic activities, such as the National Health Security Strategy, the Strategic National Stockpile, the National Disaster Medical System, and National Biosurveillance Enterprise. That should ring a bell because we talked a little bit about surveillance not too long ago. Third, they're charged with helping to improve preparedness and response coordination between HHS and other federal departments, as well as coordination between HHS and state, local, tribal, and territorial governments. Of course, we have a great example of a local official on our panel today. They're also charged with evaluating and guiding scientific priorities, especially those that address national gaps and the unique needs of at-risk populations. And finally, they're charged to coordinate with each other. I'm happy to say that the NDSB, that's the first group I mentioned, the biodefense one, has been fully operational since 2002. The one devoted to children sunset when our prior legislation expired, but has just been reinvigorated, and we're planning to have our first meeting this fall. And then the two additional ones on disability and on aging that are both brand new by our most recent legislation. We actually just closed the call for nominees about that 3 days ago. Hopefully some of you have applied for it. And we look forward to not only having that committee stood up, but also really hearing what they have to tell us. These are really important ways that we have the opportunity to hear what experts in the field are saying. And now I'd like to turn the mic over to Commander Dr. Jonathan White to tell us a little bit about some of the programmatic activities in this area.
Great, thank you, Dan. So it's a great pleasure to be here. I took copious notes during the presentations, but I have only a couple minutes, so I want to try to use them sparingly. I work in the part of ASPR which handles response and recovery operations and the sort of operational activities of ASPR. And I'm the director of the division that includes many of our programs focused on building the abilities of both local and state, tribal and territorial governments, and also healthcare systems to address the needs of populations at greater risk in disaster. So within our division, the Division of Community Mitigation and Recovery, we have the Recovery Program, which conducts long-term disaster recovery missions. We have the ASPR Tracy Program, which is HHS's disaster medical training and technical assistance clearinghouse. We have the Disaster Behavioral Health Program. We have the program for at-risk individuals, which particularly focuses on those who have access and functional needs and on children. And we have the HHS Empower program, which mines public healthcare data, billing data, to develop emergency focused data sets for state and local jurisdictions to target their public health efforts in a disaster or, for example, in COVID. So I did want to tie some of our work to, I think, a few themes in the presentations today. One issue that surfaced in Dr. Landis' presentation of keen interest to us is the issue of better integration of direct service providers and in fact, many other kinds of excuse me, of community network providers with the public health and emergency management. With the public health and emergency management systems for disasters. We did see clearly in COVID ourselves issues with PPE access. And it's interesting that surfaced in this conversation too. But it speaks more broadly to a challenge, and one that I think Mr. Sayers talked about Monroe County's work in, well, which is really important to understand. There isn't an emergency system for public health emergencies. There's the public health system. Separately, there's the various acute care and pre-hospital systems. There's the systems for skilled nursing care and post-hospital care and rehabilitative care. There's the whole panoply of behavioral health systems and of human services systems, and the community systems that help promote for independent community living, that sustain systems for access and functional needs. There's the education systems, and these systems are really not built interoperably in many communities. And so information or data that's needed for an integrated, system-wide, comprehensive preparedness, response, and recovery system is siloed or stovepiped information. People who really need to be collaborators in one another's work may not work in the same building, may not sit in the same meetings. That's even within government and industry. And then there's the further hurdle of how to appropriately involve the voices of the community itself. So these are real challenges, and we look to ways that we can leverage our existing tools like the At-Risk Individuals Program, the toolkits it produces, and ask for Tracy to help reduce those barriers. I could talk about this a long time, but I can't because of time, and I'm going to turn things over to my colleague, Robin Bosi, but I did want to again emphasize how important the issues of local coordination, of public health surveillance and meaningful data, and of integration of direct service providers for persons with disabilities into the healthcare system in emergencies really are. Thanks. Let me turn things over to Robin Sue. Over.
Thank you. Thank you so much. I know it's a challenge because we only have a couple of minutes left, but I'm just really delighted to be able to close out the series with the perspective of the importance of non-discrimination and civil rights, because certainly it was an issue that Dr. Burke brought up at the tail end of closing out the first panel on the Q&As and the importance of the Americans with Disabilities Act. And we have been talking throughout this webinar and throughout the series of how broad and expansive vulnerable populations are, and the importance of intersectionality. Today was focused on persons with disabilities, but a number of the speakers also brought up other vulnerable populations that are also protected by civil rights laws, such as communities of color, immigrant communities, refugee, migrant, indigenous, persons with limited English proficiency, and older adults. And it really does, all of that ties into, I think, another overarching theme of these series, and that is equity. And equity has been referred to in many different ways throughout various sessions in these series. Individuals have focused on health disparities as clearly something that has been underscored and highlighted during this COVID pandemic. And the perspective that I'd like to bring is that equity begins with non-discrimination. And sometimes that non-discrimination is overt. Other times it is much more implicit, built into the system, inadvertent, and really because, as a number of the speakers have pointed out, that in fact individuals are just vulnerable populations are not taken into account. So I'm getting the alert that we are running out of time. I just want to let you know that in the rest of the PowerPoint, which will be available after this webinar, I have provided a number of guidance tools, technical assistance, practical resources for compliance with civil rights that our office has put out. I also have a slide on HIPAA because our office is responsible for HIPAA as well. And at the end, you'll see contact information to how to reach us. So with that, I turn it back over to Maya to close out this, this great series.
Thank you very much for those insights. And I'm actually going to transfer it back to Dr. David. Back to you.
On behalf of the team here at the National Academies, I would like to thank our speakers and reactors for taking time out of their extremely busy schedules to share their expertise with us today. As noted at the outset of this webinar, this session has been recorded and will be archived along with the recordings from the 2 previous webinars at the website listed on this slide. We encourage you all to share this link with your colleagues and networks. Again, I thank everyone for participating in this webinar today, and I hope you will join us for future events as well. Take care.